Hello everyone, hope you're all doing good. In this video, we are going to talk about the malpresentations. Okay, so if you see malpresentations, presentations can be roughly divided into cephalic presentation, breech presentation, shoulder presentation, and then compound presentation. Clear? Obviously, we know that cephalic presentation is going to be the most common presentation, and any other presentation other than cephalic is going to be a malpresentation. And when you consider this cephalic presentation also, you have sub-classifications in that. Okay, so either the vertex can be presenting, or it can be the brow, or it can be the face, or it can be the chin. Understood? So, if you see this diagram, you will be able to understand. So what is vertex? Vertex is the space that is present between the anterior fontanel or the bregma and the posterior fontanel. Okay, so this is going to be the most common presentation. Whereas the space that is present between the bregma and the glabella, this region is going to be the sinciput, or when this is presenting, we call it as a brow presentation. And anything below this, below the glabella till the chin, when it is presenting, it is called as face presentation. Clear? So these are the different types of presentations, and which is the most common cephalic presentation? It is the vertex presentation, right? We'll also be including the brow presentation and face presentation in this chapter, right? Okay. Now we'll see what are the predisposing factors for malpresentations. In general, I am going to repeating. Now, let us see the predisposing factors for the malpresentations in general. When we speak about predisposing factors, we can further classify them as the maternal and uterine factors, as well as the fetal factors. So, first let us check what are the maternal and uterine factors. They can be contracted pelvis, or there can be pendulous abdomen, uterine leiomyomas if present, abnormal placenta previa that is causing obstruction, then hyperextension. Fetal factors include large baby, multiple pregnancy, fetal anomalies like anencephaly or hydrocephaly, polyhydramnios, or prematurity. Okay, but among these all fetal factors, prematurity is the most common cause for any type of malpresentation. Just keep that in mind, right? Now, what are the effects of malpresentations? What difficulty we are going to face when we have any malpresentation? Effects of malpresentations. There is difficulty in labor. Labor complications are more. Okay. So, what are the labor effects? This can include insufficient uterine actions. There can be chance of prolonged labor. Pathologic ring formation. Repeating. Pathologic retraction ring formation. And when this is formed, there can be even chance of uterine rupture, or cervical dilatation can be incomplete or even slow. Sometimes they can even lead to premature rupture of membranes, and there can be a need for cesarean section as well, right? We'll see the effects on the mother now. Effects on mother include maternal exhaustion. There is more stretching of the perineum, okay, because only engaging diameter that is favorable for the fetal pelvis repeating, because the only engaging diameter that is less than the maternal pelvic diameter that can pass to the pelvis easily is the vertex presentation, right? Other than that, whichever malpresentation if you take, the engaging diameter will be having a more diameter when compared to the maternal pelvis, okay. So, there will be more stretching of the perineum, and this can result in more lacerations as well. There can be more bleeding because of the lacerations that can happen in the uterus, cervix or vagina. There can be uterine atony as well due to prolonged labor. There is also an increased risk of infections, because there is a chance of early rupture of membranes, as I have told you. Then there can be frequent vaginal examinations which are done to assess the progress of labor, and as we have seen already, there is already a risk of prolonged labor as well, right? If you see, the discomfort in these women will be out of proportion to that of the contractions. Then, because the malpresentation is going to present with a prolonged labor, there will be prolonged compression on the bladder as well as the rectum that will be presenting as problems with bladder or rectum as well, right? Yes. We'll see the effect on fetus. Because there is a state of prolonged labor in malpresentations, and the uterine contractions are making its own attempt to push the baby out of the uterus, and the cervical dilatation is not going to happen, or it is not enough for the engaging diameter to pass through. And in malpresentations, we have already seen that is there is going to be a state of prolonged labor, and definitely during this labor, uterine contractions are not going to stop. It is constantly going to try to push the fetus out of the uterus, and because the engaging diameter is more, the cervical dilatation and effacement is not going to happen properly. So, what is going to be there? The fetus is going to be in a state of continuous stress, right? So, that is going to cause anoxia, asphyxia, and it can even progress to acidosis or brain death as well, okay, or it can even progress to acidosis, which can be followed by brain damage and intrauterine death, okay. And sometimes operative vaginal delivery can be attempted, that can even present with high risk of trauma. And with the malpresentations, the risk of prolapse of the cord is also going to be more, because with vertex presentation, the presenting diameter is going to engage compactly into the lower uterine segment, but it is not the case in case of any other malpresentations. Whatever you take, whatever it is, say bro presentation or face presentation or a transverse lay where shoulder presentation is happening, wherever there is going to be a small gap through which the cord is going to prolapse and come, okay. So, there can be a risk of prolapse of the cord also. So, these are the most important complications that we expect with malpresentations in general. Now, we are going to discuss malpresentations one by one, okay. First, let us speak about face presentation. So, face presentation means it is going to present between the glabella and the chin, right. If you see the incidence of face presentations, the incidence is going to be between 1 in 600 to 800 pregnancies, and the risk is going to be more in multiparous women when compared to primiparous women. And the phase presentation can be primary or secondary. Primary phase presentation means right before the onset of labor itself, it is going to be phase presentation. But secondary means after onset of labor, it is going to change. Okay, so that is secondary phase presentation. And we'll see the causes of phase presentations. Causes include anencephaly, which is going to be the most common cause. This followed by the type of pelvis. Okay, platypelloid pelvis has a high risk for phase presentation. That can be followed by multiple coils of cord around the neck for the fetus. Then there can be even thyroid neoplasms, that is preventing the normal position of head, okay, because it is going to extend the head, right. Then there is shortening of exterior muscles of the neck. Clear? So these are the causes. So all these causes will be telling you something. What is going to happen in phase presentation? When phase presentation is expected? Yes, when the baby is going to be in a state of complete extension. Clear? Right. Now we'll see what are the characteristics of the fetus in phase presentation. So if we see the lie of the baby, it is going to be longitudinal, right? Lie is going to be longitudinal. Presentation is, yes, it is going to be cephalic presentation. But when we speak specifically about the presenting part, then it is going to be face. Face is between the glabella and chin. Which will be the denominator for face presentation? Yes, it is going to be the chin again, or otherwise we can call it as mentum. Presenting diameter in face presentation is going to be submentobregmatic diameter, which is around 9.5 centimeter, right? And then you have to know that there are mento-anterior positions as well as mento-posterior positions, and among this mento-anterior position is most common, and among mento-anterior positions, left mento-anterior position is the most common one. Clear? Right. So we'll see this images now for better understanding. As I've told you, this is the face presentation. So if we see it from below, okay, if you see through the outlet of the pelvis, otherwise it is going to be the face presentation, right? And if you see that you will be taking the chin as the denominator, and it will be taken as left mento anterior, left mento posterior, right mento anterior and right mento posterior, okay? And as I have already told you, face presentation is the one which is going to present between the bregma and the glabella, right? So which is the presenting diameter of face presentation? It is going to be the submentobregmatic diameter, okay? So this diameter is going to be the presenting diameter of the face presentation, right? And it is going to be around 9.5 centimeter, okay? So submentum, okay? So mentum is chin. So just below the mentum we will be taking, and bregma means it is the anterior fontanelle. So just we are going to join the line between the submentum and the bregma, right? So that is going to be the engaging diameter, okay? So there is no confusion in this, right? Now we will see what are the examination findings you will have when you have face presentation. Most of the time examination findings, repeating. Now we will see what are the examination findings you will have when you have face presentation. So while examining, per abdomen examination will show you long axis of the fetus and uterus are parallel. Yes, because it is going to be a longitudinal lie only. Then in mento-anterior positions, you will have the back also anterior. Okay, whereas in mento-posterior positions, the back is going to be posterior. And in face presentations, occiput is going to be at a higher level than the sinciput. Okay, so occiput is at a higher level than the sinciput, and in face presentations, the occiput is felt on the same side of the fetal back, right? That means, what is the attitude of the fetus here? As I have already told you, it is going to be complete extension. Clear? Right. Now, what are the findings when you do a per-vaginal examination? On per-vaginal examination, you will be having a negative finding. Yes. So, what is that negative finding you have in face presentation? You will not be able to palpate any round or hard vertex. Okay. So, this point will be cut down. So, that will tell you that something other than the vertex is going to present. Then, you will be having a softer regular part. Okay. In that case, we have to suspect face presentation, and especially in case of left mento anterior position, which is the most common face presentation, you will be having the long axis of face, that is the submento-bregmatic diameter in the right oblique diameter of pelvis. Okay. It is left mento anterior, but the engaging diameter will be in the right oblique diameter. Clear? Right. Where will be the chin then? Chin is going to be in the left anterior quadrant. That is why it is called as left mento anterior. Where will be the forehead? Forehead is in right posterior quadrant. Clear? Right. So, if we take a maternal pelvis, so let's imagine this is the maternal pelvis. Okay. So, this is the pubis, this is the sacrum. Okay. So, when face is there and if it is a left mento anterior, the chin, so this will be the right side of the patient, this will be the left side of the patient, and we will be dividing it into 4 quadrants for now. Okay. So, the chin will be present in the left anterior quadrant, because this is going to be the anterior side and this is going to be the posterior side, right. So, the chin is going to be in the left anterior quadrant, whereas the forehead is going to be in the right posterior quadrant. Clear? Yes. What will happen is we will have uterine contractions first, right. As the uterine contractions starts, there is pressure by fundus as well as amniotic fluid. This will be causing internal rotation, and there can be 2 chances as we have seen. So, chin can be posterior or chin can be anterior. Chin anterior is the most common presentation, and only with chin anterior presentations you will have the possibility of vaginal delivery. So, what will happen in that case is there will be further descent. Then with further descent, what is going to happen is mentum presses on symphysis pubis, and when this is happening, head is delivered by flexion. Okay. Once the head is delivered, neck restitutes to the left oblique diameter. Then there is external rotation of head, and following this there will be delivery of the shoulders. Okay. So, this will cause the rest of the body to follow. Clear? Only thing you have to do understand here is, in normal vertex presentation, what will be having is, will be having the head delivered by extension, but here the head is going to be delivered by flexion. Okay, and the neck is going to restitute samely, and then it will be followed by external rotation of the head, and then the shoulders are going to be delivered. Clear? So, these 3 points are important, right? But in chin posterior positions, what is going to happen is, as the baby is descending, the chin or the mentum is going to hit against the sacral promontory. Okay, then further descent is not possible. So, whenever you are getting chin posterior presentations, better to deliver by cesarean section, and that is the only option. Can you understand? So, with chin anterior positions means you can attempt to give a vaginal delivery, but in chin posterior positions only cesarean section is possible. Is that clear? Right. But in more than 60% of the cases of face presentations, it is going to be mento-anterior only, and around 20 to 25% cases will be having mento-posterior, and the remaining of the cases, say some 10 to 15% of the cases are going to have a mento-transverse positions, right? And understand that in face presentation, the presenting diameter is going to be submento-pragmatic diameter, right, which is 9.5 centimeter. Whereas in vertex presentation, which is going to be the engaging diameter, it is going to be the suboccipito-pragmatic diameter, which is again going to be 9.5 centimeter. So, in face presentations, you can allow vaginal delivery, right? Okay. But there are more risks associated with face presentation as itself. There can be increased risk of facial edema in the fetus, or there can be laryngeal or tracheal edema that is associated with other complications, right? Next malpresentation we are going to discuss is the bro presentation. So, bro presentation, already I have explained you that it is the space that is present between the anterior fontanelle and the glabella. Yes, this is going to be the bro presentation, and if you see this pic, you will be able to understand what is the difference between vertex presentation, what is the difference between bro presentation, and what is the difference, repeating. And if you see this pic, you will be able to understand the difference between the vertex face and bro presentations. In vertex presentations, it is going to be this space that is going to present, right? So, the baby is like this, okay? Whereas in bro presentation and face presentation, in bro presentation, there is going to be incomplete extension, whereas in face presentation, there is complete extension of the baby, right? So, that one you have to understand. And what is the presenting diameter in case of, repeating? And the presenting diameter in bro presentation is going to be the vertico-mental diameter, okay, and this is the longest diameter of the fetal skull, okay. So, that is going to be around 14 centimeters, okay, right. Now, if we see the incidence of bro presentation, it is going to be 1 in 1500 to 3000 deliveries. So, this can be primary or secondary, as I have explained to you for the face presentation. Just before the onset of labor itself, it is bro presentation, or during the progress of labor, it can change to bro presentation. And we will see the characteristic of the fetus now, okay. Sorry, repeating. We will see how the diagnosis is made, okay. So, diagnosis can be made by doing a per abdomen examination and per vaginal examination. So, per abdomen examination shows the lie is longitudinal and breech is in the fundus, because it is going to be a cephalic presentation only, right. So, cephalic prominence, that is nothing but the occiput and the back of the baby are on the same side, and here the occiput is higher than the sinciput, but it is not as high as face presentation, because there is going to be a state of incomplete extension only, right. Now, we will see the pervaginal examination. In pervaginal examination, anteroposterior diameter, repeating. In pervaginal examination, you will be having three main features, right? Number one, bregma is easily palpated. Number two, sagittal suture cannot be palpated easily. Number three, you will be having the supraorbital ridges. Repeating. Number three, supraorbital ridges can be identified easily, and this will be the key to diagnosis for broad presentation. Clear? So, if we see the characteristics of the fetus in the womb, the lie is going to be longitudinal, the attitude is going to be, yes, partial extension, then presentation is cephalic, presenting part is between the bregma and glabella, that is nothing but the bro. What is the presenting diameter? Mento-vertical diameter. Okay. So, mento-vertical diameter, that is going to be around 14 centimeters roughly. Clear? And generally, bro presentations are transitory positions. Okay. They can either flex to become face presentation or extend, Bro presentations are usually transitory positions. They generally flex to become occiput presentation, okay, like a general vertex presentation, or they can extend to become face presentations. And know that this can happen in 50% of the cases. If it happens so, then vaginal delivery is possible, okay. And also vaginal delivery is possible when the pelvis is roomy or the fetus has prematurity, okay. Otherwise, generally bro presentation does not have any specific mechanism of labor, and the only mode of delivery of bro presentation is going to be a cesarean section, right. So, mode of delivery is going to be cesarean section. Clear? Right. So, in shoulder presentation, most of the times the lie is going to be transverse lie. Okay, so it is either shoulder presentation or transverse lie. That is what we are going to discuss. Normally, if we see, this is the longitudinal lie, right? So, while you are doing abdominal examination, you will be able to palpate any parts of the fetus in either side of the uterus, either in the fundus or while doing the fourth maneuver, right? But while doing examination in case of transverse presentation, you will be having an emptiness in both the upper and lower segment of the uterus, okay. Right. So, this is the example of shoulder presentation. Now, we will see the incidence. Incidence of shoulder presentation is 1 in 500 deliveries. What are the causes of shoulder presentation? See, this is most commonly seen in multipara when compared to primipara, and other causes may include prematurity of the fetus, which is the most common cause, followed by any obstructions like placenta previa. Okay, this will be the most common cause of the shoulder presentation around term. Okay, or there can be an obstructing neoplasm, polyhydramnios, multiple pregnancies, fetal anomalies, cephalopelvic disproportion or contracted pelvis, or even any uterine anomalies. Okay. So, these are the causes for shoulder presentation, and if we see the general characteristics of the fetus and shoulder presentation, Repeating. And how will we diagnose shoulder presentation? So, when we do a per abdomen examination, you have to identify it with the inspection itself, because the appearance of abdomen will be somewhat asymmetrical. Okay. Then, while doing palpation, you will be able to know that the long axis of fetus is perpendicular to the long axis of mother. So, the uterine ovoid is transversely oval here, right. So, that is what we have seen in this pic, right. So, it is going to be transversely oval. So, while doing fundal rib, no pole, and while doing abdominal rib, fetal head is on one side of the pelvis. Fetal back can be dorso-anterior or dorso-posterior. Okay. And when we do pelvic grip, the lower pole is also going to be empty. Okay. And when you auscultate for the fetal heart rate is easily heard in case of dorso-anterior position below the umbilicus, whereas it is heard with difficulty in dorso-posterior position. Okay. What are the findings in pervaginal examination? You have to rule out placenta previa before performing a pervaginal examination. Then there will be a negative finding, like you will not be able to feel the vertex, which is hard and round. Okay. And neither it will feel like a breech also, which is broad and soft. Okay. So, usually the presenting part is high, and generally, as we have seen in this diagram, the breech is going to be at a higher position when compared to the shoulder. Vaginal examination should be done very carefully so that there will not be any rupturing of membranes, because there is a high risk of cord prolapse with shoulder presentation, right. So, it is mostly confirmed by doing an USG, where you will be seeing the fetal presentation and rule out placenta previa or any maternal mass lesions present, or even any abnormalities in the fetus, right. Yes. Now, we will see the characteristics of the fetus here. So, the lie is going to be transverse or oblique lie. The presentation is shoulder presentation. Denominator in shoulder presentation is acromion process. Position, as we have seen, it can be dorso, anterior or dorso posterior. Yes, these are the characteristics. Now, we will see how we can manage if shoulder presentation is there. See, shoulder presentation, if it is found antenatally, and especially if it is found around the mid-trimester, sometimes they can go for spontaneous version by itself, okay, to a longitudinal line, either a cephalic presentation or a breech presentation, but this chance is very less, right. And other option is around 37 weeks, if you are finding the shoulder presentation, you can attempt to give an external cephalic version under ultrasonogram guidance. Suppose if it is diagnosed early in labor, then if the membranes are not ruptured, then even during that time you can give a attempt of external cephalic version. Suppose if it is found in late labor, and by chance if the membranes are not ruptured, then you can give an attempt of ECV, okay, that is unruptured. Or suppose if there is ruptured membranes, then definitely you have to go for cesarean section, right. So incisions while doing cesarean section should be of any of the following types. It can be a low vertical incision or even a classical incision can be needed in some cases, or you can prefer some other types like a U-shaped incision or T-shaped incision, etc. Okay. One of the most important complications that you expect with the labor of shoulder dystocia is that imagine that there is rupturing of the membranes and all the fluid has been let out. What is going to happen is the shoulder is going to get impacted now. Now, without any amniotic fluid, the uterus itself is going to mold over this fetus just like that, and because of the severe contractions or trying to push the fetus out, there can be chances of even uterine rupture. Okay. So, that important complication with labor you have to know, right. Uterine rupture chances are high, right. See, umbilical cord presentation is the one which is mostly seen before the rupturing of membranes or the unruptured membranes. Okay. Here the cord can be seen along the presenting part or below the presenting part, both are possible. Okay. Whereas umbilical cord prolapse, whether it can be an occult prolapse or cord prolapse, complete cord prolapse, is going to present after the rupture of membranes. Okay, rupturing of membranes would have been already occurred, and in occult prolapse it is going to present along the side of the fetal head, whereas in cord prolapse it is going to present below the presenting part. Clear? Now, if you see the incidence of cord presentation, which is also known as phonic presentation, it is going to be around 0.3 to 0.6%, and the most important complication you can expect is as the fetal head is trying to descend, it is going to compress the fetal umbilical cord, right. So, there is compression of the fetal umbilical cord. So, that will result in reduced blood supply to the fetus. Okay, that can even result in death of the fetus. So, it will be compressed between the fetal presenting part itself, say the cephalic part and the maternal pelvis, right. So, that is possible. And let us see what are the risk factors for this cord prolapse or cord presentation. So, risk prolapse include malpresentations. We have seen so much of presentations now, say it is possible in a footling breech or it is possible in a shoulder presentation as well. Then it is more commonly seen in prematurity, when the risk is more when there is a long cord as well, or there is polyhydramnios, low-lying placenta, or interventions like artificial rupturing of membranes are done. Clear? Right. So, how will we be doing a diagnosis? So, diagnosis can be done in the antenatal period itself by using ultrasonogram. Okay. You will be able to see loops of cord below the presenting part. When the cord is going to get compressed between the fetal head and the maternal pelvis, what is going to happen? First, there will be bradycardia, or there can be even chances of severe variable decelerations as well. Okay. And sometimes the cord may be seen prolapsing out of the vagina itself. Clear? Right. See, the first step in cord prolapse is that you have to relieve the cord compression so that you will be getting sufficient time to decide upon the repeating. See, the important step in cord prolapse is that you have to relieve the compression of the cord so that you will be getting sufficient time to decide upon the mode of management. Okay, for that we will be performing a method called Vagos method or it is also known as bladder filling method. What we'll be doing in this method is, the bladder is filled up with saline so that it will be pushing the presenting part higher up. Okay. When the presenting part is pushed higher up, this will be relieving the compression of the cord. Okay. So, you can fill up to 400 to 750 ml of normal saline with a Foley's catheter itself. So, this is Vago's method. Okay. After Vago's method, you have to check for the cord pulsations. Check for the cord pulsations. When it is present, you can perform a cervical examination, and when the cervix is completely dilated, vaginal delivery can be tried, okay, especially if the vertex is below +2 station. Suppose if the cervix is partially dilated, you can go for cesarean section. Suppose the cord pulsations are absent, then that means there can be fetal death even. So, in that case, don't rush up to do a cesarean section for the mother unnecessarily. You have to wait for vaginal delivery. Clear? Right. Next type of malpresentation we can have is compound presentation. See here, one of the extremities, say the leg or hands of the fetus, will be presenting along with one of the ends of the baby. Okay, in compound presentation, either of the extremities of the fetus, say hands or legs, will be presenting with the one of the fetal poles. Okay, that can be a cephalic presentation or a bro presentation, and in this the most common combination is cephalic presentation with the hands. Okay, so this is how it will be presenting. You will be having the head also along with the hands. Okay, so this is a leg they have shown here. So what is going to happen is, so when you do a pervaginal examination, you will be able to palpate the fetal head as well as the extremities together, right? Okay. So the incidence of compound presentation is going to be 1 in 1000 to 2000 deliveries, and the cause of compound presentation is again prematurity, which is the most important cause, followed by polyhydramnios or multiparity, or even when you perform external cephalic version, this can happen, right? So it can lead to complications like cord prolapse or asphyxia. So diagnosis is usually made by vaginal examination, and during labor, as I have already told you, vertex and hand is going to be the most common combination of compound presentation. And suppose if the hand is presenting at the level of vertex or it is above the level of vertex, then you can attempt to try a normal delivery. Okay, so vertex, hand is at or above the level of vertex, then you can try for a normal vaginal delivery. Suppose if it is below, means you have to make an attempt to slightly push the extremities inside and attempt at vaginal delivery. Suppose if due to any reasons there is cord prolapse or there is a decreased fetal heart rate, okay, or there is a persistent compound presentation even, okay, in these cases you will be preferring cesarean section. Clear? Last but not the least, I want to talk about unstable lie also. So, unstable lie, see, the lie is going to change repeatedly for the fetus before 37 weeks, okay, that is unstable lie. Mostly the common causes include when there is more space for the fetus to rotate around, say polyhydramnios or multiparity in which there is pendulous abdomen is present, or if the fetus is constantly trying to engage in the vertex presentation but something is obstructing the fetus head to come down. So, in case of placenta previa, okay. So, that is also possible. Usually what happens means, even if it is an unstable lie, stability can be expected around term, okay. If the unstable lie is present around 38 to 39 weeks also, then you can perform a stabilizing induction, okay. That is, you can bring the head or the breech down, and then you can start the induction of labor also simultaneously. So, what is stabilizing induction means? You will be performing an external cephalic version and you will be changing the lie into a proper longitudinal lie, and you will be starting the induction of labor simultaneously by using oxytocin. Clear? So, with this we will be completing this topic on malpresentations. Until we meet in the next video, take care, happy learning and bye bye.